All right, let's get to it. So this is our last session before lunchtime, and we've got someone who joined us yesterday. So familiar face. We've got James Alaniz, who's here with us. He's the care manager with the Good Shepherd Fund, and we're going to jump into this next session. And so, James, I'm going to pass it off to you.
All right. Thank you, Luke. Good morning, everyone. Today's presentation will be about end-of-life care, making end-of-life decisions, and how to go about it, how to be able to make the right choices, the right decisions, um, even when it comes to letting somebody go. If you have to let someone go, you'll if you attended to my presentation yesterday on medical decision making, you'll see that there's a lot of correlation. There's a lot of similarities between this one and yesterday's presentations because they're very closely related. It all has to do with medical decisions. This one has to do with more of end of life planning, but still the information that you need, um, how you go about it, the way you go about it is still essentially very similar. So again, I want to go over the role of a conservator regarding medical decisions, and they vary from state to state and individual circumstances. So this is a very fluid subject. It changes every day. It changes all the time. Nothing ever stays the same from state to state or from client to client. So in the role of guardianship and healthcare decision making, we are protecting incapacitated adults who are unable to care for themselves. We assist the individual with healthcare decisions ranging from routine appointments to surgical procedures, end of life choices. And as a conservator, we generally have broad authority to make decisions for incapacitated persons, including consenting to medical care, treatment, or services. One of the most important things and first things you want to do when you want to gauge or possibly talk about medical decision making or end of life decision making is your client's level of understanding. Understanding your client's level of understanding is crucial when planning for end of life care. When evaluating your client's level of understanding, you can ensure that they receive the highest care possible and amount of respect, respect their autonomy, and maintain their dignity throughout the care process. So, things that you want to know, questions you want to ask is how much does your client understand? How much do they understand a medically complex situation and issue? Can they grasp complex issues related to their care? How much involvement do you anticipate they will have in making their own healthcare decisions? Assess their level of perception and degree of intellectual disability or cognitive impairment. Levels of intellectual disability go from mild to moderate to severe to profound. So there's going to be a huge difference between having this conversation with somebody who has a mild intellectual deficit versus someone who's profound. And you probably wouldn't even be assessing this or asking these kinds of questions with somebody with a profound intellectual disability. You'd be making these decisions on your own. How you go about that, and that all includes how much information you have and how much general knowledge you have about your own client, and because you are making the decision for them. And finally, do you believe they will be able to make decisions for themselves at any point? So evaluating your client's level of understanding, you can ensure the highest quality that they will receive. So one good example would be my client, Timmy. He lives in the Central Valley. He has moderate intellectual disabilities, functioning adult, but he still needs help with his ADLs, activities of daily living. He has to be reminded to change his clothes, to brush his teeth. He has no concept of money or responsibility. But he's a great conversationalist. You could talk to him. You talk about sports and the Raiders and going out to eat. He loves Cane's chicken fingers, and he's verbal. He's a good conversationalist, and he likes to smile and talk to everyone. Everybody is his friend, and he's a great guy. So I asked him, I said, "Hey, Timmy, if your heart were to stop working or you were to stop breathing, would you want us to do everything we can to help you, to get your heart started again, even if it means doing chest compressions and putting a tube down your throat and maybe even shocking you to help you breathe?" And his response was, "Okay, James, let's do that, okay?" And I said, "All right, Timmy, we'll do that, you know." And then a few minutes later, I posed the same question to him, but this time I said, "Okay, we'll do everything for you like you want. But you can also decide for us not to do anything if your heart stops. You can decide that you want a natural death to occur, to just let you pass away and keep you comfortable and not do anything to help you." "Okay, James, let's do that." So where does that leave me? Where do I even go with a response like that? Because he said yes to both extreme ends of the conversation. So in the situation like this, I would take his current medical condition, his current health, any illnesses that he might have, prognosis, to help me decide what he would want. And right now, as it stands, he is a full code. In other words, we would want everything to be done for him to keep him alive because he is relatively healthy. He's good, strong guy. He's had, I think, maybe 3 surgeries in the past 2 years, and he just flew through all of them like nothing. So he's a very strong guy. And so, it's don't necessarily have to make any end of life decisions for him, but still, this gives you the idea that sometimes clients just do not grasp complex medical situations. And this is why conservatorship exists. Our goal is to help those who cannot help themselves. As I said yesterday, be the voice to those who have no voice. Another client in the Valley, Central Valley, her name is Erlene. Just about the same level of moderate intellectual disability. Great conversationalist. She's depressed. She has depression. She's labile. She has anxiety. She rents her own home, but she has 24-hour care. She has one person with her throughout the day and night. She has no concept of money. And so she has a significant, substantial special needs trust. So she's very susceptible to influence and family. So we try to keep her protected and isolated. And so she has her own caregiver. She's verbal, needs constant supervising. So I asked the same questions to her, the same questions that I posed to Timmy, I said to her, and her response was, "Oh, I don't know. I guess so. Or maybe not. I don't know what to do. I don't want to think about it. I guess so." So that was a yes, I think. And then she came away with, "I want to be buried in the cemetery next to my parents. I have a plot there, so when I die, I will go there. It's paid for." So again, can you assess, does she have a grasp of this complex medical situation? And I would say no, she does not. She kind of does, right? But then again, she's labile. I don't know. I think so. Yes, maybe no. And with Tim, he was, yeah, okay, and go, let's do plan A. All right, let's do plan B. Okay. So again, his level of understanding was not very high. So for these clients, I would have to take into account their medical history, their background, their illnesses, because with no family, basically it's gonna fall back on me to make an end of life decision when that time comes. If the client is nonverbal or has profound intellectual disability, and there is no family, you're going to find yourself alone. And I'm sure we have, or some of you, or all of us have found ourselves in that decision making position of having to do everything on your own. So how do you go about gathering information to make a rational, again, there's that my favorite word, objective decision? What information can you gather from the clients themselves, right? Asking them questions, talking to them directly, current diagnosis, prognosis, the health condition. Are emotions or an emotional attachment playing a role in the end of life care decision? Absolutely. So this is where we need to keep emotions and emotional attachments separate from objectivity so that you can make a rational decision for your client, not based on emotion. So diagnosis versus prognosis. A lot of people don't know what the difference is. And not to say anything bad about them, but family can often misinterpret these words. Palliative care, hospice care, they think it means the same thing. Diagnosis, prognosis, they don't understand what it means, but they think they do. So it's very important to know what a diagnosis is versus a prognosis. So diagnosis is the art or act of identifying a disease from its signs and symptoms. Prognosis is the prospect of recovery as anticipated from the usual course of disease or peculiarities of the case. It's a forecast, it's a prognostication. So you've been diagnosed with um, pneumonia. So they're going to give you medication and the prognosis looks good. Or your client has had a brainstem stroke. That's the diagnosis due to lab tests and CTs and MRIs. They've had a brainstem stroke. The prognosis is poor. No chance of recovery. That's a prognosis. That's a forecast. So, as a conservative, what does this mean to you? It means that you'll be able to create an effective care plan for a client with a terminal diagnosis, end of life, cancer, liver cancer, disease, or a manageable prognosis, which involves a comprehensive approach that considers their medical, emotional, social, and legal needs. So, if your client comes down with or has a manageable prognosis, that may involve rehabilitative therapy, occupational therapy, physical therapy, you develop a care plan. Or there's a terminal diagnosis when someone has liver cancer and it has spread to their liver or it's spread to their lungs and now it's spread to their abdomen. So now we start changing over from making medical decisions to making end of life decisions, possibly. So factors to consider to ensure that the care plan addresses all aspects of your client's needs, prioritizing their comfort and quality of life, and involving the family if they have one and support network in the process. So factors to consider when making end-of-life decisions is the age, medical history, diagnoses. Tim, he's 63, he's in great health, limited medical history, but he doesn't have a lot going on in terms of comorbidities versus somebody who is extremely obese, has end-stage renal failure, diabetes, a history of seizures, these types of things, all these comorbidities, they factor in. And when you have to make an end of life decision, we talk about quality versus quantity of life. So what's better? Do you want them to live longer, or do you want them to live to have a quality of life versus a quantity of life? Would they benefit from medical intervention? So if there is something like an issue, a cancer that was going on, a process that was going on, and radiation therapy and chemotherapy are presented, would it make their life better if we did it versus if we did nothing? Would their life be the same afterward? These are things that we have to consider in part of creating an effective care plan for a patient with a terminal diagnosis. One of the most important things is a POLST, which stands for Physician Orders for Life-Sustaining Treatment. In California, it's called the POLST. In Colorado, it's called the MOST, M-O-S-T. I'm not sure if it's applicable in Oregon or Washington or what it's called or if it's the same thing, but it is a critical document in the end-of-life care planning because it translates a patient's preferences into actionable medical orders. In other words, this is what I want done if I should go into cardiac or respiratory arrest. So the importance of having one is it provides clear medical orders. It provides the current medical condition. What is likely to happen as your condition progresses, which is called the prognosis. Your goals of care, what do you want to do? Consistency across different care settings, hospital, home, hospice. The POLST translates to all those different care settings. Immediate access in an emergency for medical personnel to quickly understand and honor the patient's wishes, and it provides legal protection. So I do want to add that here in California, if you have a client who has a pulse, and let's just say that they are DNR, DNI, which means they want nothing done, no intervention, let them die a natural death. If they have that on file and they are in a group home or they are in a facility and they code, okay, they suddenly just stop, they're unresponsive, they stop breathing, no heartbeat. By policy, these places have to initiate CPR and they have to call 911. In which EMS is called and they continue with CPR or whatever they need to do, intubation, shocks, defibrillation. They have to do that by policy, whether or not they have a DNR, DNI. It's until they reach the hospital. Now, hopefully the group home or the facility has sent all the paperwork to the hospital, in which case the hospital, first thing they ask for is, do they have a POLST or do they have an advanced directive? And then they want to find somebody in charge, which is ultimately going to be you. So you will get that call from the hospital and they're going to say, we have so-and-so here. They're not doing so well. We've been doing 3 rounds of pressors already and heartbeat has not been attained. They're been intubated. What do the pulse says DNR, DNI. And so, they will get witnesses and they will confirm that this is what is wanted, this is what is needed, and they will make that choice. And you have to make that decision to stop treatment, according to the post. So just as a side note, in California, even though a client will be DNR DNI, if they do go down at home, CPI will be started, and that all changes once they reach the hospital. So there's different types of treatment on the post. You can ask for full treatment, selective treatment, comfort-focused treatment, palliative care, and hospice care. By understanding these documents and by understanding these goals clearly, you can create a comprehensive and effective end-of-life care plan that aligns with your client's values and wishes. Full treatment, okay. Full treatment involves all life-sustaining treatments such as resuscitation, intensive care, mechanical ventilation, and invasive procedures if necessary, putting in arterial lines, putting in a PICC line, IVs. So the assessment questions you want to ask your client would be, are you willing to undergo any medical treatment to extend your life, regardless of the potential for pain or discomfort? How do you feel about aggressive treatments that might prolong life but not improve the quality of life? So aggressive treatments meaning CPR, defibrillation, intubation. And again, you have to assess the intellectual disability of your client. How well can they understand this question that I just asked them? Your treatment goal is to have everything done that is medically appropriate and possible to attempt to save your life. You would be okay going to the hospital and being in intensive care on a breathing machine. That's full treatment. Selective. So you can ask for, maybe CPR, but no intubation and no mechanical ventilation. So, CPR, shocks, but nothing else, nothing more than that. That is a selective treatment. Your treatment goal is to treat medical problems that can be reversed. You'd be okay with going to the hospital, but just to get medicine that would treat an infection that you caught. You would not want surgery or be in intensive care. So that's selective treatment. That's less than full treatment. Comfort focused prioritizes relief from pain and symptoms over life prolonging measures. It aims to ensure quality of life and comfort. Is your primary goal to remain comfortable and pain-free, even if it means foregoing treatments that might extend your life? What are the most important factors for you in maintaining your quality of life? So these are questions you want to ask your client if they're able to understand. And the treatment goal for comfort-focused treatment is to make you as comfortable as possible and allow death to happen naturally. You would not want to go to the hospital or be on a breathing machine. If no decision is made, you will receive the standard of care. Okay, so if you get to the hospital and there's no pulse, they don't know who you are, they don't know what's going on, they are going to give you the standard of care, which means everything medically reasonable and possible to save your life, including CPR and intubation. So, again, I'm reiterating what I just said earlier, that care home policies vary. Even if you are DNR, DNI, they will call 911 and transport to ER. Palliative care. A lot of people don't fully, especially family members, don't really understand the dynamics and what palliative care means. They think it means end of life care, they think it means you're giving up, when it's actually quite the opposite. This is specialized medical care for people with serious illnesses, chronic, that are focused on providing comfort from symptoms and stress. So the goal is to improve quality of life for both the patient and the family. So you're going to be receiving treatments for your illness, but you're also going to be given comfort measures to keep you comfortable and keep you safe. It's to provide symptom relief, comfort, and support to enhance your quality of life. It's not necessarily the end of life issues. The palliative care, people think that's what it is, but it's not. It's actually a more intense way of treating your illness while at the same time making you comfortable. Hospice care is designed specifically for patients who are nearing the end of life, typically when curative treatments are no longer an option. The focus is on comfort and quality of life. That's what it is. They improve your quality of life and emotional well-being with compassionate and supportive care. So any treatments that you've been receiving, any chemotherapy, any radiation, all of that stops. The only thing that you'll be getting at this point is comfort care, which means sedation, medication to help you feel comfortable and help you be pain-free. This is when you have reached the end and there is no other viable option. Power of attorney versus conservatorship. In California, yes, a conservatorship can override a power of attorney. A conservatorship override, a court can appoint a conservator for someone. The conservator gains legal authority over the ward's personal, financial, and medical decisions. Revocation of power of attorney. While a durable power of attorney can be revoked by the person who granted it, a conservatorship can only be revoked through a formal court process, which takes quite a bit of time. If there's a conflict between the conservator and the agent named in the power of attorney, the court will decide based on the best interest of the ward. So the court may modify or terminate the power of attorney if necessary. So they're going to be signing for the conservatorship. In summary, conservatorships provide more authority and permanence than power of attorney arrangements. When considering these options, it's crucial to consult with legal professionals to ensure your wishes are clearly documented and understood. It's especially important to plan ahead, as details can become complicated if the client is unable to communicate their preferences. Advanced care directive, family involvement. When you involve families in advanced care directives, you need to assess their level of perception. Assess the family's ability to understand the complexities of end-of-life decisions. So, maybe some of us have experienced this. I certainly have. When we're dealing with families, some family come across as perceiving themselves as to understand everything that an advanced care directive is. They know what that is. They want to do this, they want to do that, and they don't really understand what is being talked about. Desires and wishes. Identify the family's desires and wishes regarding the client's care. Family history and relationship. Consider the family's history and their relationship to the client. Depth of involvement. Evaluate the extent of the family's involvement in the client's daily decisions and issues. So what this basically means is a family might want to step in to help make end-of-life decisions, but you need to understand just how close the family is. It may be a situation where the family has never been involved with them, and all of a sudden they are. They want to make decisions for them, and this could actually move over into if a patient has a trust, if there's money involved, all of a sudden family comes out of nowhere and they want to make decisions on their behalf because they have an advanced care directive. We have power of attorney. We have this, we have that. Just stay strong and stay solid in your position as a conservator, and you're going to be doing everything in your client's best interest. Medical care, medical staff and caregiver involvement. So the depth of involvement, determine how well the medical staff or caregivers know your client. Identify any end-of-life wishes expressed by the medical staff or caregivers. So a lot of times they don't have families, so the family, the medical staff, the home group staff, they become their family. And so you're going to want to talk to them, and you're going to want to ask them, what do you think they would have wanted? What do you think we should do? Now, I'm not going to do what they say, but I certainly want to listen to what they have to say, because they're the ones that spend most of the time with them. This is where emotional dynamics comes into play between the medical staff and caregivers and your clients. Sometimes, and I've seen it happen, when people get so wrapped up and so emotional into their clients' lives and they want them to live forever, that they want everything to be done, when in fact it may be best to let them go. It may be best to put them in hospice. But because of emotional attachment, emotional involvement, that can sometimes cloud people's judgment because of the emotional impact. So I have a couple of case studies I'd like to go over. The first one is David. He was 54 years old. He had Down syndrome. He could hold simple conversations, but not very complex. He had spatial awareness, but he was very easily influenced. He was diagnosed with an aggressive liver cancer, which spread to his abdomen and lungs. So he also had severe scoliosis, so his spine was very severely bent. And because of his anatomy and physiology, it was very, very hard to get a biopsy from him. And there really wasn't a lot that could be done. I met with the medical team. We talked about care options, and surgery was very risky due to his anatomy. Chemotherapy, radiation therapy, they just thought I was going to buy time. And I asked them how much time, and they said 6 months tops. Okay, the prognosis was poor. So there's his diagnosis. Prognosis, my forecast, it's poor. The oncologist, the cancer specialist, refused to treat. So when I first heard this, I was thinking, what do you mean? I don't get it. You don't want to treat him? Not that we were going to treat him, we're thinking about it, but I just thought that was kind of weird that he refused to treat. So I put that in the back of my mind. During his hospitalization, he was in the fetal position. He was barely responding, not eating. Sometimes he would mumble, sometimes he would talk to you and smile as much as he could. He was just a wonderful, sweet guy. Staff loved him, and they wanted everything to be done to prolong life. Okay, so this is where we get into emotional thinking. They wanted, and this phrase, a return to normalcy. Don't we all want that, right? We want everything to go back to the way it was. And in situations like this, there is no going back to the way it was because I understood the situation from my medical experience, from talking with the medical team. If I'm being objective, I knew that there was no coming back from something like this, but the staff wanted to have everything done. So I considered the family involvement, medical team diagnosis, which was poor, and the prognosis and staff involvement. So I gathered up all that information. And then I assessed David's level of understanding. Can he understand what is happening? Can he decide for himself and consent for treatment? And then that is when it hit me why the oncologist refused to treat. Because the next question was, can he perceive chemotherapy and radiation therapy? He would not have been able to with his Down syndrome and his personality, his intellectual difficulties. He wouldn't have been able to understand that. All he would have seen was people walking into his room, giving him medicine through his IV, and it would have made him sick, nauseous, vomiting, would have caused his hair to fall out. It would have caused pain in his joints and his muscles, and he would have been scared. He would have been confused, all for the sake of what really amounted to buying a few extra months of time, which those few months of time would have been spent in the hospital, scared, confused. So I had to weigh that, and I understood why the oncologist said he didn't want to treat because he wouldn't understand what was going on. Now, I could have consented for him to receive chemotherapy, but I'm also taking into consideration what the oncologist was thinking. So I had to weigh the quality of life versus quantity of life. So the staff would have loved to have him for another 6 months, but those 6 months would have been pretty bad for him, and it wouldn't have made any difference in the outcome. So I had to take that into consideration as well. So in the end, I need to evaluate my treatment options. Surgery, risky, probably not going to do anything. Chemotherapy, radiation, recovery time, the overall outcome, consider if a cure is expected or if the goal is to extend life, quality versus quantity. Viability, are we realistic? Are these realistic options, or are we just grasping at straws? Understanding David's awareness of his condition can significantly inform your decision-making process. As a conservator, given David's inability to understand, I was responsible for the medical decisions that truly aligned with his best interest. Clear objectivity. You have to make a decision that is free from bias. You have to maintain perspective. You have to logically determine the next steps because at this point, everyone is kind of making their own decisions and wanting to make their own choices. So you have to be logical about it. Emotional detachment. Avoid making decisions based on influence or emotions. Rational decision making, not allowing emotions to drive my decision and potentially worsen the situation. So what I came up with was my decision was after considering everyone's input, I evaluated the risk of surgery and chemotherapy, and that chemotherapy and radiation will only buy time. And given David's inability to comprehend what was happening to him and the emphasis on the quality of life, I decided to opt for hospice care. I thought that this will allow David to spend his final days at home, peacefully surrounded by loved ones, which is exactly how it turned out. We discharged him home to hospice, because thankfully the home was able to care for hospice. And that's another thing I would like to bring up, that if your client is in a group home or facility, it would be a good idea to ask, do you provide hospice care at the facility? Because if they do not, and you decide to enter a client into hospice care, that means they're going to be transferred to another facility, which can provide hospice care. And hospice care is wonderful. I've never met a team that I didn't automatically love. Hospice is great. But for the client, you're moving a client that may have been at the home for 5, 10, 15 years into another strange environment where they don't know anybody, they don't know where they're at, and so it could make it could make things worse, right? And sometimes these things have to be done, but it would be good to know ahead of time, before you have to make this decision, does that home provide hospice care? And that's what happened. We discharged him home. He went home, and 4 days later, he passed away, surrounded by everybody. He even recovered a little bit, which sometimes happen with people who are nearing the end. They get better. He was able to eat some some ice cream, a little bit of pizza, and he was smiling as usual. And he just went to sleep one night and didn't wake up. So he was surrounded by his loved ones, and that was for me the best case scenario for him. Um, and ultimately, the home staff understood where I was coming from, and the medical team understood, and they supported my decision. So often we pursue all possible treatments to fix the issue, even when it cannot be fixed. And we need to ask ourselves why we do this. Is it for the family or for our own emotional attachment? It's essential to look beyond these emotions to make decisions that truly align with the patient's best interests. Another case study is Sylvia. Sylvia was a 68-year-old female, moderate intellectual disability, Down syndrome, dementia. She could talk in 4 or 5 word sentences, decreased enunciation, but she can make her needs known through hand gestures and facial expressions. She was able to recognize staff, but she had an indirect, non-focused gaze. She was in the hospital for sepsis and pneumonia. Prior to this discharge, before she went home, she suffered cardiac arrest with resuscitation, followed by intubation. So she had a G tube in place for her stomach. She was intubated, and she was coded, and they brought her back. The prognosis was poor, and she was not expected to survive. I think at that point, too much damage had been done to her heart. So care options, possible hypoxic injury. So hypoxic means a condition of low oxygen. So her brain went without oxygen, went with low levels of oxygen for quite some time. And so the prognosis was not good. She wasn't expected to survive. The home asked me to delegate medical decisions. Basically, they told me, you decide. You're the conservator. You decide. We don't know what to do. Which I had never been told that before, but this is what the house wanted. So I said, okay, that's fine. I looked at the chart, I looked at the medical records. Of course, I knew all about her history. I spoke to staff to get their perspective. I asked about family. So I notified the family. And what is crazy to understand is that the brother had believed that she had died years earlier, and he was shocked to hear that she was still alive. So in the future, I'm thinking, am I going to take your considerations into account? I'm going to listen to you, but I'm not really going to listen to you because you didn't even know she was alive. So if it could have been a situation where he could have come at me with, well, I have a power of attorney, or I'm a family member, I want this, I want that. No, I wouldn't have allowed that to influence my decisions. So there was a variety of factors to consider when we're thinking about end of life care, because at this point, her prognosis was not good. She wasn't going to get off the ventilator. She probably wasn't going to recover from this hypoxic injury. So I need to start thinking about end of life decisions. What am I going to do? One of those things that we need to think about is the role of religion. Sylvia was Catholic. So the role of religion in end of life decisions can differ significantly due to diverse customs and practices. So, cremation was out of the picture. Organ donation was out of the picture. Family history. Their intermittent presence, they were based in Texas in Sylvia's life, presented a limited connection and influence in daily decisions made about her care. So, family was not involved. They were involved, but they were not involved. And, like I said, the brother didn't even know she was alive still. Prognosis was very poor. She had respiratory issues, multiple comorbidities. No funeral arrangements or burial rituals were stated or pre-planned. So creating a dilemma between cremation versus burial and cost versus wishes. So because of this case, and this was about, I'd say 4 years ago, I make it a point to, in every single one of my clients, I try to find out, or if they don't, I try to initiate a burial policy or prepaid funeral arrangements. So it's just that because when this happened, nobody wanted to do anything. The home didn't want to deal with the mortuary. The family didn't want to have anything to do with it. So it was all up to me, and I had no clue what was going on, because there were no arrangements made. There were no burial wishes. There was no burial policy. So I had to, deal with the mortuary, the coroner, I had to find a place. I had to find a cemetery, a Catholic cemetery. I had to find a place where to bury her, and we had to arrange for payments. And so all of these things are going to fall upon you when there is nobody left, or actually nobody who wants to make a decision. This falls upon you as a conservator. And so it's always good to have some knowledge if possible, or to create a burial policy so that you can have some idea in speaking with family, what would they want? What do because sometimes family have burial plots. Sometimes they have a notion of where they want to have their family member buried. So it's good to have this information when it comes to it. So in crafting the treatment plan for the conservator, I considered input from the team, from the insight from the staff and the nursing team at home, as well as Silver's medical history. So based on this comprehensive assessment, I made the decision that in the event of another life-threatening episode, no resuscitative measures would be taken, allowing for a natural end to her life. This choice was reflected in updating the post. So the good thing about a post is it can be changed. It can be changed anytime, as many times as you want, as long as it's noted by a physician with physician number and date. It can be changed back and forth. You don't want to do that, but it can be. So we updated to DNR DNI. She was full code, signifying a preference for no intervention. So despite these measures, she experienced respiratory difficulties requiring readmission. She went back home and she required readmission to the hospital. And then, tragically, she passed away the following night in the hospital rather than at home, which was kind of sad, but that's what happened to her. And with her passing, legally, conservatorship comes to an end. So as a conservator, I can say, I'm done. That's it. I have no more legal responsibility for her. But that's not who I am. That's not who the Good Shepherd Fund is. We don't do that. And she had family that really wanted to have anything to do with her. The home didn't know anything about arrangements, so I had to make all the arrangements, even though she had passed away. Even though I had no legal responsibility as a conservator, she was still my client. I still saw her that way. She was going to be my client until they buried her. So I made all the arrangements, coordinations with the funeral homes, and I decided upon cremation, followed by placement in the cemetery in accordance with her wishes, because this was what she had wanted to do. What staff member had told me a long time ago, this is what she would have wanted, but there was nothing in paper, but it's what she told me she would have wanted. And so this is what we decided for her. And also money is limited too. She had no money. And so you have to take that into consideration too, considering that burial expenses can be quite expensive. My next case study is Mary. She was a 79-year-old female, Hispanic, moderate intellectual disability. She had a lot of comorbidities: health, seizure disorders, cerebral palsy, osteoporosis, gastric erosion, cancer, dementia, gastric esophageal reflux disease, or GERD. She was partially blind. She was alert to the environment. She was aware of others in the room, and she was verbal and adequately able to communicate her needs and preferences. She was non-ambulatory, but she was able to feed herself, brush her teeth, and she was mostly dependent on ADLs as far as bathing and cleaning and showering. She had a history of prior suspected abuse and neglect at the previous home, and she was subsequently transferred to a new home where she settled in well, and the staff loved her. So medical overview, she had a lot of respiratory issues, a lot of UTIs, seizure activity, continued health decline. So they decided to put in a PICC line. And actually, a medical decision wise, I authorized and consented for a PICC line. And PICC line stands for peripherally inserted central catheter. So they put in a very large IV line in an artery. And this is for long-term IV antibiotics, medications, nutrition, blood draws. So they don't have to keep poking her for blood draws. They can draw it out of the PICC line. And unlike an IV that has to be changed every certain number of days, a PICC line can stay in for quite a long time. And it's just the one central hub where they can take all blood as necessary or put in antibiotics. And it's a great thing to have if you're looking at long-term chronic situations. A PICC line is a good thing. She was medically complex and unstable. She had somnolence with periods of non-responsiveness. So somnolence is almost when someone goes into like a dream-like state. They're half asleep. They're during the middle of the day, they're snoring, but then they just alert, they wake up their eyes, and somnolence is kind of like being a half asleep, half awake. And then there'd be periods when she wouldn't be responsive. So again, we're talking, like I talked about yesterday, failure to thrive. She had a significant decrease in food intake, refusing to eat very little, increased evening arousal, but no significant health improvement. So during the evenings, it seems she perked up. She came around. She was able to talk, and so I actually arranged my visits to be in the evenings around 6 or 7 when she was more awake and alert, as opposed to the rest of the day where she was somnolent. She wasn't really responding to anything. She had heavy family involvement. 6 people: brother Robert, niece, grandniece, great grandnieces, nephews, and they wanted everything to be done to keep her alive. Because at this point I had reached out to the family. We were talking about end of life decisions, and they wanted everything to be done full code. Now I don't know how they or where they heard this term, but they kept mentioning the term "all heroic measures be done," um, but relented. I told them, I explained to them the situation. I told them that this is not a good idea. That was she. It would be better if she was a no code because she's so sick right now. Um, and they relented and they made her a no code, a DNR, DNI. Okay. The pulse stated full code. The situation was explained to the family. And so we made her a no code. We entered her into the hospice due to multiple healthcare issues and declining status. Um, and so we entered her into hospice. And the family is very dedicated to being in her life. And one of these days, about a week before she passed away, I was visiting her and I told her, okay, mom, I'm gonna come back in a couple of weeks to check up on you and see how you're doing. And she said, okay. I'm just so tired, mijo, which is son, Spanish for son. She said, I'm just so tired, mijo. And this was when she was lucid, when she was, arousable in the evening. And she's just so tired. And that spoke to me. That kind of spoke to me. And I thought, she's just tired. She wants to go home. She wants, she doesn't want to keep going like this. And so I got that. I understood that. So over time, over the next few days, the family changed their mind and requested that she be made full code, asking for her to be taken off hospice and again, give her a chance to recover. They demanded that the pulse be changed to full code, believing that with proper nutrition, she would bounce back and return to normalcy. So again, there's that family dynamic of how much information do they know? How much can they understand complex situations? Because they were thinking that the brother is actually telling me, he really sat me down and told me, I think that if we brought her some albondigas, which is meatball soup, that she would get better. I think she'd get better if we just gave her some soup and she would bounce back, right? And a return to normalcy. There's that phrase. Everybody wants a return to normalcy. And I knew, the medical team knew, that this was not going to happen. But at this time, she was one of my first clients when I first started working. Okay. So this is one of those times when I was really trying to make everybody happy. I didn't want to anger anybody. I didn't want to end up on the wrong side of people's intention. I wanted to make everyone happy, right? And I was letting emotions play into this. And so I agreed. I agreed to their wishes and changed her status to full code. So back again, we go to full code. This was a medically difficult case. And the family involvement was making the end of life decisions more complicated for me because I knew where we should have gone, but I was allowing this family to influence me. How do I make everybody happy? Who do I serve? I have to weigh the quality versus quantity. I have to consider the prognosis, medical options, family wishes. All of these things come into play. So I had a final meeting with the family and the medical team, and the medical situation was explained to the nephew, and the nephew agreed and understood the gravity of her condition, and the nephew felt it would be best to place her in hospice care and designate her as a no code. I agreed with the family's request, and during a conversation with the nephew, reiterated the belief that Mary is at the end of her life and should be allowed to pass peacefully. I supported the hospice team's assessment that she is at the end of her life and that no further interventions should be made. As a conservator, I must act in Mary's best interest while considering the family's concerns and striving for a middle ground. I waited for a call from her brother, Robert, to discuss and see what transpires next. So I can go ahead and ask you, what do you think happened next? So Yeah, the family insisted on transferring Mary to the hospital for, there's that word again, heroic measures to preserve her life. Despite explaining the situation to the family again, they remained adamant about this decision. Mary was transported to the hospital where she passed away that night. Resuscitation efforts were futile and she did not die peacefully. So this is something that is going to bother me forever. And I'm, I use this as a lesson to never let this happen again. She was 98 pounds and they did CPR on her, which is a very aggressive, violent act. I've done it myself in ICU and ER trauma more times than I can remember, and it's very aggressive. They intubated her, they shocked her. So she didn't die in peace, which is what I wanted. But I allowed my emotions to get into, I allowed the family to influence my decisions because you know, you reflect back on it. You say, what could I have done? What should I have done? Right. From a legal standpoint, ignoring the family's wishes and allowing Mary to die peacefully in hospice would have been the compassionate choice. But this decision would have exposed us to legal risks, including potential family charges and legal repercussions, because that's what I was thinking about as well. Emotionally, and from a legal standpoint, the family still wanted everything to be done. And it would look as if I was denying their wishes, going against what they wanted, when in fact, I was actually advocating for my client and she should have been allowed to die in peace. And sad, tragically, that's not what's happened. So who are we doing this for? And why are we doing this? We have to think about these things. Family involvement, we have to understand and address the family's wishes and concerns. Incorporating insights and observations from the caregiving staff, valuing the medical team's expert opinion is a crucial factor alongside my own judgment. Dynamics to consider, emotions such as guilt and unresolved family issues, potential impact on family dynamics. Sometimes maybe there's unresolved guilt or issues with the family member. Maybe there was something that was unsaid or not done, or something that was done and they feel guilty about it. And they feel that as long as they're alive, they won't have to deal with the guilt. And so they want to have everything done to keep them alive. It doesn't matter if they suffer or not. They're not thinking about quantity of life. They're thinking about quality. As long as she's alive, my conscience is free. And so these kinds of things family think about, the family dynamics. So you cannot allow that to become a factor in your own decision making. You have to remain objective. And this case is what I use as an example of to remain objective and to never allow this to happen again. And I haven't since then. So my last case study is Christine. She was a 98-year-old female. She was blind, dementia, immobile. She was nonverbal in hospice care. She had property. She had a large home. She had assets. She had quite a bit of money. And she was in a good care facility. Very caring nurse, homeowner. She was in a wonderful facility. I loved them. She had two daughters, and one was a retired nurse. And for me, that was a big red flag. Now, if anybody is a nurse out there, I apologize. I don't mean anything by that. But it can be a red flag when you have a retired nurse. Because of that, or the reason why, because of that, because the nurse would come and visit. She'd change her care every day. She would interfere in the daily routine, insisting on delegating daily activities, and difficult to advocate for Christine properly as her conservator. I couldn't really get a word in edgewise because she was basically stomping all over everybody. As a retired nurse, I know what I'm doing. I know what I'm looking at, and you guys are doing it all wrong. Which was as far from the truth as you could get, but still that's how she saw it. The care team members who took care of her were intimidated by her, and they constantly called me for help, always the phone calls and visits for me to go. Relocation request. So the family wanted to move Christine to a newer, better facility closer to them so they can manage her care more directly. I think it was like 5 minutes from their home versus 30 minutes that they had to travel to where she was currently. But as a conservator, I could have said, yeah, we can move her, we can relocate her, but there was no way I was going to do that because I was acting in my client's best interest. And in my opinion, she was getting great care where she was at. There was no need for her to influence me or for me to move her because the family wants me to, because they want to save time on their travel. Um, So there was always the conflicts, there was always allegations, there was a bitter dispute over her overall care, and it created a really ugly situation, and it didn't have to be. The family constantly made insinuations of abuse and neglect by the care staff. And even during, so much so that a family member locked herself in Christine's room to protect her from alleged abuse. And so the sheriff had to be called. That's how bad it got with them, with the family dynamics. And she is already in hospice care. So my role as a conservator, as I had to navigate this whole conflict, and I had to ensure that Christine's best interests are prioritized. Now, to be blunt, I could care less what's going on with the staff or with the family. I really could care less. All I'm concerned about is making sure that Christine is safe and that she is comfortable, which is what was happening during that whole time. And I had to balance the family concerns with professional assessments and care standards. I also have to address legal and ethical implications while maintaining a focus on Christine's well-being. So, again, the insinuations of abuse, um, I had to weigh that with, okay, do we give in? Do we cave? Because I don't want to get in trouble. I don't want any legal stuff going on, so I might as well let them have their way. No, because I had to remain strong and remain true to who my client was, which was Christine. And basically, the client herself was caught in the middle. She became a pawn in the family's conflicts. And it's crucial for a conservative to remember your duty to the conservatee amidst familial disputes. Seeking guidance. I got information from the staff, from the medical professionals, from peers to inform decision making. I had to consider all of that. I had to consider all the perspectives and expertise to formulate a comprehensive plan. Should we continue with hospice? Should we not? I had to evaluate the benefits and drawbacks of all the various approaches and determine the purpose and the potential outcomes before deciding on a course of action. And what happened ultimately was that she did end up passing away peacefully at home, surrounded by her daughters, both the nurse and the other daughter. Um, and then what was really interesting, because after she had passed away, the drama died, and then the very next day, a battle over her assets began. The two daughters went at each other over the division of the assets, and so that was a whole other thing that got up, and so that really put into me that the process that this family dynamics was involved in, and that was really sad and strange to look at because of the way they treated their mother. But in the end, I did my duty for Christine, and she did pass away peacefully in hospice, and that's all I really cared about. You must be prepared for any situation. Okay. So in conclusion, familiarize yourself with all the pertinent details, right? You need to know medical history, family dynamics, if there is any prognosis, medical terminology. It wouldn't hurt to, take a class of medical terminology, go online to get medical terms, hypoxic, anoxic, hypertension, hypotension, edema, right? Pitting edema, erythema, all these different terms. It would be good to know these. And I think somebody made a comment yesterday on doing an assessment on a client. And I do want to stress that I don't want you, when you're doing an assessment, a physical assessment on your client, I'm not expecting you to assess and diagnose. I think it's more important to assess and to look and to make note of anything that you see that does look wrong, like swelling or redness, to make a note of it. Even if you can take a picture of it so that the next time you visit, you can see whether that redness has disappeared or if it's gotten worse. Collect as much information as possible from various resources. You may find yourself relying solely on your own resources, so gather as much data as you can. Trust your instincts, right? Go with your gut until proven otherwise. Your intuition can be a valuable guide in uncertain circumstances. Don't hesitate to ask questions to clarify any uncertainties. If you don't know what's going on, ask, especially when it comes to medical terminology and discussions with the medical team. If they mention something to you that you don't understand, or you kind of have an idea about it, stop them and tell them, hey, what do you mean by that? What does that mean? And you'll see that most of the time, almost all the time, they're more than happy to slow down and explain to you what's actually going on. Because in the end, effective communication is the key to making informed decisions. So, value of information. Information serves as the cornerstone of effective end-of-life care planning. It empowers your decision making and ensures the best possible outcomes for the individual. While emotions are natural, it is important to maintain a level-headed approach in end-of-life situations. Emotional reactions can cloud judgment and hinder clear decision making, whether it be emotional decisions on the part of the family or on the part of you. A well-informed conservator is best equipped to navigate the complexities of end-of-life care. By staying informed and objective, the conservator can act in the best interest of the individual under their care. And that concludes my presentation. I want to thank you guys all for listening. If you have any questions, I'd be more than happy to answer them. I think we have a couple of minutes left.
Yep, we got about 2 minutes left.
I'm looking at the chats and thank you for all the comments. That's very, very thoughtful of you. I appreciate that.
Right. Well, if there's no final questions, we'll wrap there. Thanks again, James. Really appreciate your time, and thanks for sharing your expertise and your wisdom. And so, what we're going to do is we're going to wrap this session up. It's lunchtime, and so we'll see everybody back at 12:30, same place. Thanks again, James, and see
Great.
everyone real soon in
Yeah,
about an
thank you.
hour.
Thank you, everyone. Thank you, everyone. Thank you, Luke.
Thank you.